So we'll talk about the vagina today and how tumors there and especially tumor-like conditions can be a challenge in diagnosis. The vagina is a little different than either the cervix or the vulva, and so it is worth thinking about separately. Although most of the staging and other conditions are similar. Thank you. So first of all, we'll talk about things that are benign that can be confused with the malignant ones. So one of these is vaginal adenosis, which is not terribly common here, probably, but it was found to be associated with DES exposure. This is a steroid drug that was used with some pregnant women in the 1950s especially. And so they started having children. Their children started growing up. By the time their children were in their 20s and 30s, it was discovered that they had this condition, and this was leading to cancers. So it is defined as columnar epithelium that can be of many different types and occurs in the wall of the vagina. Have you seen any of these? It's quite uncommon now, but when you see it, it can be very concerning for well-differentiated cancer. This is what it can look like if it's a very full-blown example, is this granular reddish tinge here to the mucosa that reflects glandular rather than squamous type of mucosa, although most of it tends to be beneath the squamous mucosa. We can have very complex glandular appearance, but all fairly low grade, very low nuclear to cytoplasmic ratios. And usually, as I said, it's beneath the squamous mucosa that you have this. So it looks like maybe endocervix with squamous metaplasia a lot. So the differential can include things like, ectopic cervix or duplication of the cervix sometimes. You have to know where the biopsy is coming from. Sometimes it's this type of mucinous epithelium. Sometimes it can be more squamoid or papillary. This is clearly endocervical type squamous mucosa. Here's an example with ciliated epithelium. So you can also get tubal type of epithelium as well. And then sort of like salivary glands where you get necrotizing sialometaplasia, well, sometimes you can get squamous metaplasia in adenosis as well. So a very broad spectrum of histologies that can all occur in this disorder. Now, vaginal cysts can come in several different varieties and also can have different mucosal lining surfaces. So these can be due to Mullerian remnants, or they can be an epithelial squamous inclusion, such as might happen in a post-surgical state, post-episiotomy, or endometriosis can also cause this as well. And we can also see occasional mesonephric type cysts in this area. These would usually be in the lateral wall, and these would usually be in the posterior wall. These can be anywhere. So here's an example of a Mullerian type cyst that merges with squamous mucosa and can have endocervical or tubal or even endometrial type of epithelium. And if this is massively dilated, it can be a significant mass lesion. Some people think this may arise from areas of adenosis because of the various types of epithelium we can see. Mesonephric cysts, again, lateral wall of the vagina, a very simple cuboidal type of epithelium. And these may also occasionally have small glandular remnants that may look like adenosis. This is more common in the cervix. We'll see them there as well. And then the last lesion that can sometimes be concerning is if someone has a hysterectomy. Occasionally the fallopian tube can prolapse into the vaginal cuff and present with this very papillary, inflamed mass type of lesion. Another lesion that is concerning when you see it is the postoperative spindle cell tumor. And the vagina is the most common location for this, although it can also occur in the urethra and the bladder and so forth. The history is very important. Some recent surgery in this area. This will also stain with cytokeratins as well as stromal markers. And these can get fairly large fairly quickly because they grow quite rapidly. So here is the typical appearance. You see it's very blue, it's very cellular. You would look at this and think, wow, sarcoma or something concerning like that. And it has this very fascicular type of pattern with lots of mitoses, but no atypical mitoses. So cellular, fast-growing, benign. Here's another example. You see one high-power field, 1, 2, 3, 4, 5 mitoses, one very small field. So lack of any atypical mitosis and recent surgery critical to making or knowing this diagnosis. Fibroepithelial polyps in the vagina can be quite interesting compared to fibroepithelial polyps elsewhere. These are usually adults. Many of them have a history of some hormonal change, pregnancy or birth control pills or something. And they can become fairly large, so they can look a little bit like botryoid sarcoma. And they may even have surface atypia or dysplasia or ulceration, so they can begin to become concerning. Single or multiple, as in this case, we might wonder about condyloma or other sorts of things, but these will have some distinctive findings. And one of those findings is this unique stroma that says, oh, this is not just an epithelial proliferation, there's something in the stroma that is abnormal as well. So here are some of these stromal cells. You can see multinucleation, some atypia, and these will usually be Vimentin and Desmond positive, and they may also be ER and PR positive, indicating they're hormonally sensitive. So when many of these patients have some hormonal manipulation, that may be what's causing the growth. In a few cases, not commonly, these can look quite atypical and may resemble a sarcoma. So you have to see the whole picture to remember and understand that these sarcomatoid stromal giant cells do not mean that it's malignant. It may still be a fibroepithelial polyp. Here's another example with a very cellular stroma. Notice it comes right up to the epithelium. There's no normal stroma between the epithelium and this stroma. That's important in differentiating it from rhabdomyosarcoma. We might think about solitary fibrous tumor or endometrial stromal sarcoma. The vascular pattern is prominent, and so endometrial stromal sarcoma could become a consideration. If you had to do a stain to differentiate this from this, maybe a CD10 stain would help you. CD10 would be positive usually in endometrial stromal sarcoma, but should be negative in fibroepithelial polyps. The aggressive angiomyxoma that we talked about last time also comes into consideration here, but it doesn't have the same vascular nature that that lesion does. Tubulosquamous polyp is a very unique lesion, although there's also a correlate in the cervix. This is usually postmenopausal women. So women where estrogen levels have fallen and you're getting a little more androgenic stimulation. In those women, you can get these little lesions in the upper vagina that are often positive for prostatic markers. So this may be a little bit of either a prostatic analog or something like that. The differential would include the Brenner tumor and a benign mixed tumor. But this is usually upper vagina, whereas this we'll see is usually lower vagina. So here's what these look like. A normal surface, and these little tubules with squamous lining, maybe some cholesterol, keratin, tubulosquamous polyp. And they're usually quite small, less than 2 centimeters, so fairly small. Other lesions we could see occasionally in postmenopausal women. You'll get gas emphysematous change from infection or gas-forming organisms, or maybe other processes. Endometriosis is also not infrequent in this area, particularly if there's been some trauma and so forth. It is not, however, particularly related to intra-abdominal endometriosis. Yes?
How can different diagnosis between tubulosquamous polyp with cervical chronic and squamous lesion?
So the question is, how can we differentiate tubulosquamous polyps from cervical ectopic cervix, or with metaplasia, cervical squamous metaplasia, or dysplasia? So the location will usually be vaginal, not cervical. Has not been described squamous dysplasia in this lesion. So there is not significant nuclear atypia or coilocytotic change. But I agree that squamous metaplasia involving adenosis or something like that could be confusing. If you get any positivity for prostatic markers, that would clearly differentiate it from the cervical squamous metaplasia type of lesion as well. So here's a gross example of endometriosis. Here's the soft tissue, fatty tissue, mucosal surface, and then we see these polypoid processes here, which turn out to have endometrial type tissue. So if there's been a laceration or something like that, an implant has occurred, you can get repetitive growth of endometrial type tissue, which may become polypoid. Not all cases are polypoid. Here's a case that sort of mimics adenosis with a granular mucosal appearance, and here a surface is intact with underlying endometrial glands and stroma. Malakoplakia will occasionally form a mass type lesion and can have this very histiocytic appearance. This image doesn't show them particularly well, but you want to look for the Michaelis-Gutmann bodies, the little small blue bodies that are usually intracytoplasmic, like that little one there, I think.